Please start.
Good evening, everyone. I welcome you all in today's webinar Oncology Cancer Treatment Updates 2024. I immensely welcome Dr. Arpit Jain, Consultant Medical Oncology, RGCI, New Delhi.
Okay, thank you. Good evening, dear esteemed attendees. With great pleasure and anticipation, I welcome you all in this webinar on the latest update in the lung cancer field. So we will be discussing various aspects of the lung cancer management, particularly related to the EGFR mutation testing, including its management in the early lung cancer and also in the metastatic settings. I would like to extend my gratitude to all the distinguished speakers for joining us in this endeavor. Without much ado, I would like to invite our first speaker, Dr. Bhushan Parmar. He's a dear colleague and working in Rajiv Gandhi Cancer Institute. He will be delivering the lecture on the molecular biomarker testing pertinent in with the lung cancer field. So, Dr. Bhushan sir, good evening. Over to you. Dr.
Hello.
Bhushan, you can start.
Sir,
Yes.
good evening. Thank you, sir.
Yeah, good evening.
Good evening, everybody. So my topic is biomarkers in metastatic non-small cell lung carcinoma. Uh, First of all, sir, is it possible for anybody to play the slideshow for me?
Yes, sir. Yes, sir.
So, first of all, a brief outline of the topic. We will be discussing the lung cancer scenario in India. Then biomarkers testing in required in non-small cell lung carcinomas. Then what is the current status of and the evolution? How has it evolved over the years? The biomarker testing in lung carcinomas, and finally the key takeaways. So this slide is showing the burden of lung cancer in India according to the Globocan 2020 data. As we can see in the first pie chart diagram, it is showing the number of lung cancer cases amounted to about 5.5% of the lung cancer of total cancers. If we talk about both male and female population, irrespective of the age. And the second slide, it is showing with respect to the lung cancer, the number of new cases in 2020 of lung cancers among male population across all age group, and we can see it amounted for about 8% of the total cancer cases in the males, irrespective of all the age. So next slide, please. About 50% of the patients with advanced non-squamous, non-small cell lung carcinomas they have a driver mutation which can be targeted by some tyrosine small molecule inhibitors, and which have been various approved by the various clinical trials, and they are FDA approved. For example, the as we can see in this pie chart, the EGFR sensitizing mutation amounts to about 17% of these cases who have a driver mutation target. So then ALK, about 7% of the cases, and the corresponding drugs for the EGFR sensitizing mutation, as we all know, are these first generation erlotinib, gefitinib, then second generation afatinib, then are the third generation osimertinib, and this decometinib is also second generation drug. These are useful in EGFR sensitizing mutations. Then we have other EGFR mutations, which amount to about 0.1 to 4% of the cases and are mostly EGFR exon 20 insertion mutations. And these drugs, like first generation TKIs and second generation TKIs, and even the third generation TKIs, they are not effective in these cases. And the drug is effective for these exon 20 insertion mutations are amivantamab and mobocertinib. Then the largest group, as we can see, it is KRAS. The KRAS, which amounts to the 25% of the driver target mutations. But right now, the KRAS subgroup of this, which is the G1C mutation, which accounts for the 13% of the KRAS mutations, they are targetable by sotorasib and adagrasib. Similarly, the next the significant group of patients, about 7% of non-small cell lung carcinoma patients, they have ALK rearrangements. And the drugs effective are crizotinib, alectinib, ceritinib, lorlatinib, brigatinib. Then followed by this, we have MET mutations, accounting to 3% of the cases, and the MET exon 14 mutations are targetable by capmatinib and tepotinib. Then there are HER2 amplifications, which could be targeted by trastuzumab deruxtecan, but these are very rare, amounting to about 2% of the cases. Then we have ROS1, 2% of the cases, targetable by the same crizotinib, which was effective for ALK rearrangements, and entrectinib. Then we have BRAF, 2%. The drug which is effective against BRAF V600E mutation is dabrafenib in lung cancers. Then 2% of the cases, RET fusion, selpercatinib and pralsetinib. Then another 1% of the cases, NTRK1 gene fusions, and the drugs are entrectinib, larotrectinib. Then other are MAC1, which is less than 1%, PIK3CA, which amounts to about 1% of the cases. So we can see that it becomes very important to test the patients to identify some meaningful mutations to have a good clinical outcome and minimize the toxicity also. So this slide is the next slide, please. This slide is showing the importance of biomarker testing in non-small cell lung carcinomas. So studies have shown that patients with identified actionable mutations who receive appropriate targeted therapy, they have improved outcome. Now this graph is plotted against the time in months and the survival probability. The upper one, the upper curve, which is blue in color, is with respect to it relates to the corresponds to the targeted therapy, while the red one is no targeted therapy. So we can see these curves, they are separated and run parallel to each other up till 50 months. Even at 50 months, the difference was significant. Next slide. So now, what are the guidelines which guide us for biomarker testing and taking further decisions in advanced non-small cell lung carcinomas? The routine testing for molecular aberrations is recommended for all the adenocarcinomas, but only in special circumstances for squamous cell carcinomas of the lung. So we have different guidelines. ESCO 2018. Which recommends testing for EGFR, ALK, ROS1, BRAF, MET exon 14 skipping mutation, RET gene fusions, and TRK gene fusions, and there is no recommendation for KRAS mutations. And then PDL1 expression, which guides us for the use of immunotherapy or response. It also acts as a predictive marker for immunotherapy. Then there are NCCN guidelines, which recommends testing for all these biomarkers. Then, according to ESMO 2020 guidelines, it is recommended to test all the lung adenocarcinomas for EGFR, ALK, ROS1, BRAF, and TRK and PDL1. Sorry. Then ISSLC guidelines. These are 2018 guidelines which recommend for testing at least for EGFR, ALK, ROS plus KRAS mutations. Next line, please. Next slide, please. Now, what are the methods of tissue testing in non-small cell lung carcinoma? First is the DNA sequencing or NGS or PCR. So it can detect insertion, point mutations, and deletions. It detects aberration in specific genes like EGFR, KRAS, BRAF, HER2, and MET. The NGS could be full or select. It could be a panel of some selected genes. Then there are RNA sequencing panels. The RNA sequencing panels are especially useful to detect the fusion, this chromosomal fusion mutations, because these are very large DNA molecules, the fusion molecules. So it is better to go for RNA sequencing panel because it does not include the introns. It is more sensitive for this ALK rearrangements, ROS1, RET, and TRK. Then there is IS. Then the third method is by ISC or FISH. The FISH detects ALK ROS1. It is a highly specialized and can be faster. ISC, it can be used to detect ALK ROS1. It is an easy test, fast, but not reliable or sensitive enough to guide the treatment. So we have to confirm the results by means of another test. But ISC can also detect PDL1. No, next slide, please. So, what is how the biomarker testing in non-small cell lung carcinoma has evolved? So, this slide is showing that initially the tissue was the only source of DNA. After biopsy or complete resection of the tumor, formalin-fixed paraffin-embedded blocks were made. Then another source is cytology. The source could be exfoliative cytology or FNAC. The exfoliative cytology could be from urine, ascitic fluid, pleural fluid, sputum, or cerebral CSF, or any residual supernatant. So again, from this source of cells, we made non-cell block sites. Then there are liquid biopsies. Liquid biopsies, they are the source is blood or cyst fluid. The liquid biopsies contain the RNA and also the other structural component of the tumor cells. Then for detecting, then finally with the various sophisticated methods are followed and DNA and RNA is extracted, whatever is required depending on the final method of analysis to be used. For example, PCR, and we have cancer gene panels, some targeted mutations, we use DNA. And as we have seen, RNA, it is for the gene expression panels and also for detecting the, in a case of NGS, for fusion mutations. Then for protein, this is the final translational product of the messenger RNA. That is the final product, which may be truncated or a complete protein or some aberrant protein which contains the mutated, the replaced amino acids because of the mutation. So basically, this the right side of the slide, the key personnel are surgeons, pathologists, and other allied health professionals. While for this conducting this PCR, NGS, etc., we have a pathologist and other this molecular biology stuff. Next slide, please. So, what is the importance of biopsy? Biopsy is capable of establishing the diagnosis, determine the histological subtype, and further it provides material for the biomarker testing also. So, histologic subtyping is like, first of all, squamous or non-squamous. Then for biomarker testing, primary tumor, or metastatic lesions, they are both equally suitable. Bone biopsy can be suboptimal because we have to perform decalcification of the acquired tissue, and that can lead to degradation of DNA. Then another option is to go for liquid biopsy. Then we have cell-free circulating DNA in the plasma. The then for if we have to test for EGFR, ALK, ROS1, BRAF, V600E, NTRK, RET, MET exon 14 in all the non-squamous non-small cell lung carcinomas, we have to use broad NGS testing to detect most mutations. And at the same time, since now we have small biopsies, mostly CT guided biopsies in metastatic setting, or bronchoscopic small biopsies, so tissue sometimes may not be sufficient. It might not be sufficient. Now, for squamous non-small cell lung carcinoma, these tests are conducted only in special settings, like in young patients who are never smokers or light smokers, and if on biopsy we have a mixed histology. In all non-small cell lung carcinomas, we have to test for PDL1 expression. So, since the patient presents to us usually in advanced stage, and he might be symptomatic for pain or some other shortness of breath, etc. So, we need to complete testing within 10 to 14 working days of the biopsy. It is recommended, but it might vary. The time might vary depending on the method of sequencing used, and like NGS or PCR, whatever, which varies according to the clinical profile of the patient. The role of circulating tumor DNA. The circulating tumor DNA testing has the potential to be applied across all the stages of non-small cell lung carcinoma and throughout the treatment pathway. First in the diagnosis and then treatment selection. So ctDNA can help us in for the diagnosis and mm, to guide the further treatment selection in the upfront setting. Then after the once the treatment has begun, it can be used to monitor the prognosis and also to monitor the response to treatment by measuring the level of the amplitude of drop and the decrease in the levels of circulating tumor DNAs. Then when the patient becomes has progressive disease on the first line, at that time also, if we want to go for a rebiopsy, or we want to look for some other mutations or any evolutions which could have occurred with the during the course of time, so it becomes challenging to get new tissue. It might be painful for the patient also and uncomfortable to get repeatedly biopsied. So here also the ctDNA testing comes into play. However, it should be taken with a pinch of salt, because ctDNA may never replace tissue biopsy entirely, but could play a complementary role to support the treatment selection in patients with non-small cell carcinomas. Even then, the role of circulating tumor DNA to detect minimal residual disease after surgery in early stage disease who have been treated with curative intent. For example, a patient of non-small cell lung carcinoma whose disease has been completely resected. In these patients, the circulating tumor DNA is can guide us to confirm the like even after surgery, if the patient is having circulating tumor DNA, then this prognosis for this patient is different from that patient whose blood is negative for circulating tumor DNA after surgery. And after that, also circulating tumor DNA can evaluate the efficacy of the adjuvant treatment, whether the adjuvant treatment was able to convert ctDNA positive status to ctDNA negative status, and in what time. Next slide, please. So this slide is showing comparison of tissue versus liquid biopsy. So as we know that the sample acquisition in tumor tissue will be tough as compared to the liquid biopsy. However, still the tumor tissue it is considered as the gold standard. And if we talk about the sensitivity, the lower tumor cell content is acceptable with tumor tissue with sensitive techniques in 1 to 10%. While for liquid biopsy, very sensitive methods are required as circulating tumor DNA may comprise about less than 0.1% of cell-free DNA. Because cell-free DNA can contain the normal DNA released from the mostly from the hematopoiesis going in the bone marrow, and this generates a lot of background noise which interferes with the measurement of circulating tumor DNA. And coming to the last point of that is the evidence of clinical utility, the substantial evidence for initial targeted treatment selection and subsequent treatment after targeted treatment failure in advanced non-small cell lung carcinoma exists for the tumor tissue, but for the liquid biopsy, it is less, but it is increasing with time, with the course of time. Next slide, please. So, what are the advantages of NGS? NGS has a number of advantages over single gene tests, as the number of clinically actionable biomarkers has increased and new biomarkers have been discovered. The ability to evaluate all known molecular alterations in a single test has given NGS a major advantage because of the parallel sequencing. Because in less, the turnaround time is is less, cost is less, and the uh, results are very elaborate. We can test for several genes in parallel sequencing at a single time. While for the single gene test, it to test like the Sanger sequencing, it will take a lot of time to test for 3, 4 genes, which might not be of clinical utility because we need to start the treatment early for the advanced cases. So, next slide. Next slide. EGFR mutation in lung adenocarcinomas. The sample types used for EGFR mutation testing are formalin fixed, paraffin embedded sections, fresh tissue, frozen, or alcohol fixed specimen can also be used for PCR based assays. Cytology samples are also suitable, and cell blocks are preferred over the smears. So this table is showing the summary of studies of the concordance of EGFR mutations in primary versus the metastatic tumors in same patients. And it has been concluded by the authors that the discordances between EGFR mutation status in primary tumor and corresponding metastatic sites are rarely seen. Now, EGFR mutation test in early lung cancer, the NCCN also recommends EGFR testing in case of early stage non-small cell lung carcinomas. Uh, in advanced cases, we have to test for all the patients. And in the early stage non-small cell lung carcinoma, we have to test for EGFR mutations. So here again, the advantages of NGS over PCR. The one study showed that 48.6% of EGFR exon 20 insertion mutations identified via NGS are missed by PCR. And out of the 17 most common EGFR exon 20 insertion mutation variants, only 4 can be identified via PCR. Now, the ALK rearrangements in the non-small cell lung carcinoma. In most of the cases, the LKIH is 93 to 100% sensitive and specific compared to fish. There is a false positivity rate, but it is very low, 0.1% with fish. IHC method, it is less expensive, quick, and hence it is more widely adopted. For ROS1 rearrangements in non-small cell lung carcinoma, So this is the algorithm. So non-small cell lung carcinoma, whether adeno or non-squamous with who have been non-smokers with mixed histology or young patients. Um, the ALK, EGFR, then ROS1. For ROS1, we go for ROS1 ISC. If ROS1 is positive, ROS1 ISC is negative, then we stop with there. If ROS1 ISC comes out to be positive, we reconfirm by a second method, that is FISH or some another molecular assay, or we test directly for ROS1 fish. If ROS1 fish is negative, then we stop there only. If ROS1 fish by fish is positive, then we consider reconfirmation by a second method, that is by ISC or another molecular assay. For detection of elevated ROS1 protein levels by ISC, it is cost-effective screening prior to the confirmatory fish testing. So this is the preferred method, to go for ISC than for fish testing. Now for the next slide, please. BRAF mutation in non-small cell lung carcinomas. The BRAF V600E mutation is present in more than 50% of the BRAF mutation cases, and it is thought to be more prevalent in smokers. The non V600E mutations, such as V600K, G466V, and G469A, are less prevalent and occur in 17% of the patients with a BRAF mutation. Overall, BRAF mutation occur in 1 to 5% of the patients with non-small cell lung carcinoma, commonly adenocarcinomas. And the currently approved therapies for BRAF V600E include dabrafenib and trametinib.
Excuse me, Dr.
Yes,
Bhushan,
sir.
I think
Yeah.
the slides are not concurrent with your talk, huh? So the slide now displaying is EGFR mutation testing. I think you are on the BRAF mutation testing.
No, actually, I'm
That
not
ones.
able to share my screen because EGFR I have discussed. Right now, I am discussing the BRAF mutation in non-small cell lung carcinoma, slide number 28. Next slide, please. So this slide is showing the c-MET receptor tyrosine kinase and MET exon 14 skipping mutation in non-small cell lung carcinomas. They play a normal role in embryogenesis and wound healing. In cancer, MET exon 14 skipping mutation cause in-frame deletion of the juxtamembrane domain, resulting in increased stability and constitutive kinase activation. And it accounts for 3 to 4%, seen in 3 to 4% of non-squamous non-small cell lung carcinomas and 20 to 30% of the sarcomatoid cancer. Majority of the MET exon 14 skipping mutations can be detected with DNA NGS, but increased sensitivity is seen with RNA NGS. Next slide, please. So what are the methods for MET exon 14 mutation detection? ISC and FISH are not recommended, and the test recommended is NGS, because has the potential to detect many other mutations, and RNA NGS, as we have discussed earlier, is the most sensitive. Next slide, please. RET receptor tyrosine kinase and RET fusions in adenocarcinoma of lung. They have a normal role in during the neural and genitourinary development. In cancer, RET gene rearrangements give rise to chimeric cytosolic proteins with constitutively active RET kinase domain. They are seen in 1 to 2% of the non-squamous lung carcinomas and 10 to 20% of papillary thyroid carcinomas also. Majority of the RET fusions can be detected by DNA NGS, but increased sensitivity is there with RNA NGS. So the methods for detection, next slide please. The methods of detection for RET fusion are ISC. The pros of ISC is potential local implementation, and the disadvantage is significant false negative results and significant false positive results. So it should not be used. Regarding the fish, the pros are potential local implementation, And again, the disadvantage is the significant false negative and positive results. So it can be used, but under rare circumstances. For DNA NGS, the pros are simultaneously we get mutation information, while the disadvantage is poor coverage of some intronic areas due to repetitive sequences, and it leads to reduced sensitivity. But it is this we should consider testing by DNA NGS. But finally, the best method appears to be RNA NGS. The pros are obtain fusion partner information without intron coverage issues, and directly access the fusion expression, that is the final fusion protein. And the cons are highly dependent upon RNA quality, and poor quality can lead to reduced sensitivity, and it should be considered, if available, the method of choice. Next slide, please. Testing for NTRK fusions. The options are IHC, RNA or DNA NGS, FISH, and RT-PCR. Each of these methods have their own advantages and disadvantages. The RNA NGS is most sensitive, while the IHC is widely available. And the choice of assay will depend on the institution to institution and on the resources available and the clinical scenario. Reflex testing to NGS versus IHC reasonable for non-small cell lung carcinoma due to low prevalence of NTRK fusion should be done. Now, what are the methods for detecting the NTRK TRK fusions? IHC. The advantages of IHC are rapid results and widely available, low cost. Disadvantages are the it will take some tissue. There is depletion of tissue. Then fusion partner and position will remain unknown, and it is a less validated test currently. Then the fish, the advantages are rapid results, while the disadvantages are depletion, again depletion of tissue. Fusion partner and position remains unknown, and it can be difficult to interpret. While for NGS, the potential advantages are potential for multiplex testing. There is less depletion of tissue, and more tissue remains available for later testing if required. The fusion partner and positions can be determined, and NGS, RNA NGS remains the most sensitive method. While the disadvantages are little bit more turnaround time, so we have to wait longer, and the
Bhushan sir,
cost of tools. Sir,
I think you can conclude in next 2-3 minutes.
okay, sir. Okay, sir. I'll conclude. So next is HER2 mutation. The HER2 mutation is present in 3 to 5% of the adenocarcinomas, and these are mostly exon 20 in frame insertions. These are mutually exclusive with other mutations and have presence of these mutation gives patient a worse overall survival than other type of lung cancer mutations. PDL1 testing for PDL overexpression in non-small cell lung carcinoma. PDL1 antibody clones, ISC platform and scoring system in lung cancer are shown in this slide. And we can see the DECO platform, Ventana, and DECO as these are the various platforms. The immune checkpoint inhibitors for DECO, pembrolizumab, Ventana, durvalumab, atezolizumab, and nivolumab. The diagnostic type was companion for deco pembrolizumab, Ventana durvalumab complementary, and so on. The scoring system we for the this leftmost part of the slide, the PDL1 positive, TC more than equal to 1%, or PDL1 high, TC more than equal to 50%. Then similarly in the another systems, this next slide please. This is showing the PDL1 testing by using different antibodies, and a different scoring system is adopted depending on the antibody used to detect the PDL1, which is shown in each of these diagrams. So biomarkers for immunotherapy, it is a controversial topic. PDL1 sole current biomarker which is able to guide immunotherapy, but it is imperfect. The PD-L1 negative tumors can still respond to immunotherapy, albeit mostly when added to chemotherapy. Might be because of the synergistic effect between the checkpoint inhibitors and the chemotherapy. Then the tumor mutation burden, which is a formal marker for response, but not currently utilized widely because there were conflicting correlation with survival in the checkmate studies. Then MSI high or MMR status in case of lung, it is not used or relevant in lung cancer. And LAG3 possibly related to resistance to immunotherapy, and it is under being evaluated. So to conclude, last slide please. The biomarker testing in non-small cell lung carcinoma has evolved from single gene to multiplex testing. The multiple disciplinary meetings help in better understanding of the sample and test requirements. Sample should contain adequate tumor content, at least 10%. And the ideal test is 2 weeks or 10 working days. High throughput platforms such as NGS can be used to screen several genes at a time. Thank you. Yes.
Thank you, Dr. Bhushan sir. It was a very extensive presentation and the very
Thank you, sir.
crisp presentation on the various molecular testing aspects. So I would like to invite our next speaker, Dr. Raghav Anand. He's doing his DNV super specialty from the prestigious Rajiv Gandhi Cancer Institute at Research Center. So he will be delivering his lecture on the various aspects of the lung cancer management in general. So Dr. Raghav, good evening. Over to you.
Good evening, sir. Thank you for this opportunity, sir. Can we play the slides? Actually, I'm logged in through the phone, so slideshow.
Yeah, sure. Tech team, please coordinate.
So the topic for today's overview of lung cancer. I would like to thank the organizers as well as Arpit sir for this opportunity to present this. So this will include a brief overview of the treatment as it is today, and with various aspects of newer immunotherapy as well as targeted agents. Next slide, please. So the burden of lung cancer in India. This is the Globocon 2020 data, as Bhushan sir had also shown in his slides. So we can see that lung cancer in males is the second most common cancer, and overall, if we see in both sexes, it is the fourth most common cancer in case of both incidence, prevalence, as well as deaths. Next slide, please. Coming to the staging system, so there are certain changes in the AJCC 8th edition as compared to the AJCC 7th edition. So the staging is as follows. So basically, a T1 disease is is a disease with a tumor size of less than 3 centimeters. T2 is 3 to 5, T3 is 5 to 7, and T4 is more than 7. So we told that the T1 disease is less than 3 centimeters. This can be divided into T1 A, B, C. A is less than 1, B is T1 B is 1 to 2, and T1 C is 2 to 3. And a T1 tumor should not involve the main bronchus. Coming to a T2 staging, so that is about 3 to 5 centimeters. In that, T2A is 3 to 4 and T2B is 4 to 5. And this tumor can involve it involves the main bronchus but does not involve the carina. It invades the staging can either be based on the tumor size or certain characteristics. We have described the size. The characteristics include things like if the tumor invades the main bronchus bronchus, but not the carina. That is also a T2 disease. If it involves the visceral pleura, it is a T2 disease. Or if there is associated atelectasis or obstructive pneumonitis, then also it is a T2 disease. A T3 disease is one which is 5 to 7 centimeters in size, and or it can include certain characteristics such as that there is a separate tumor nodule in the same lobe as the primary tumor, or there is invasion of the chest wall, which includes the parietal pleura. Visceral pleura was T2, or there is invasion of the phrenic nerve. Coming to T4, that is more than 7 centimeters, or there is a separate nodule in a different lobe of the lung, different lobe of the same lung. If it's in the opposite lung, then that is stage 4. If this in the separate lobe of a different lobe of the same lung, then it is a T4 disease, or there is invasion of the great vessels or the diaphragm. The nodal staging. So nodal staging, as we will discuss ahead, how it is staged. But in this N1 disease is the ipsilateral peribronchial or hilar node. N2 disease is an ipsilateral mediastinal or subcarinal node. And N3 is any contralateral node or ipsilateral as well as contralateral supraclavicular or scalene lymph nodes. And M1 is anything which is distant. Next slide, please. So the tools for staging can be both based on imaging as well as there can be certain invasive tests. Imaging includes a CT of the chest or a PET CT. And this is always accompanied with an MRI brain. And invasive testing includes a bronchoscopy or a mediastinoscopy. Next slide, please. So a CT versus a PET CT for staging. So CT alone has a limited role due to a low sensitivity and specificity. And the main benefit of doing a CT is that it helps, it is the initial test and helps to select the site for the sampling. And PET CT is one which increases the PET CT as compared to a CT has a better overall sensitivity as well as specificity. Next slide, please. So there is something known as an occult N2, which is the ipsilateral mediastinal or subcarinal node, which are not visible on imaging. So there are certain risk factors for an occult N2. These include the central tumors, large tumors, or tumors with a high SUV max. Next slide, please. So mediastinal imaging staging, as we had discussed. So to sample the mediastinal nodes, we can either use an invasive or a less invasive or a more invasive technique. The less invasive technique is an EBUS, which is most commonly used. And in certain circumstances, we require more invasive testing to make sure of the nodal status, which includes a mediastinoscopy. Next slide, please. So the recommended technique is an EBUS or an EUS. But if the clinical suspicion of N2 involvement is very high, even after a negative EBUS, then staging with a mediastinoscopy is recommended. This is not routinely done. Next slide, please. So when is invasive mediastinal staging indicated? So there are certain conditions in which with a negative, if there is a negative EBUS, we may go ahead with a mediastinal invasive mediastinal staging, or if we can stage it with a EBUS itself. These include a centrally located tumor, tumor more than 3 centimeters. There is discrete N2 disease on PET CT, and there is a normal mediastinum on CT with a positive mediastinum on PET. However, if there is a bulky N2 on imaging, we do not need to sample it. Next slide, please. This is this mediastinal staging protocol is something which is what we have discussed till now. So on a PET if mediastinal lymph nodes are negative and there is a low probability of an occult N2, then we don't need to sample it. If the mediastinal lymph nodes are negative, but there is high probability of a occult N2 as the risk factors for which we had discussed previously, then we need to sample these and with an EBUS, and if negative, then we can proceed with our treatment. However, if positive, the treatment changes. If the mediastinal lymph nodes are positive on imaging and they are bulky, then we don't need to sample them and can consider them to be positive. However, if they are non-bulky, then we need to confirm our diagnosis with an EBUS, and treatment is based on the mediastinal staging, as we will discuss ahead. Next slide, please. So this again tells us the lymph node station accessibility with various techniques of mediastinal staging, both less invasive like EBUS or EUS, or more invasive like mediastinoscopy, which includes VATS or cervical and extended mediastinoscopy, and the various level of nodes which are accessible with these techniques. Next slide, please. And this tells us about the sensitivity of our imaging as well as our invasive techniques for the mediastinal nodes. So we can see that with an EBUS, the sensitivity is almost 90%, EBUS or an EUS, and this goes up even more with mediastinoscopy. However, that is an much more invasive procedure and has its own demerits and is only done in very certain specific indications, as we have discussed. Next slide, please. So the evolution of therapy in lung cancer. So as we know that over time, there have been certain advances in lung cancer, both diagnosis and management. And today in this era, we are now in the era of molecular pathology and targeted agents, immunotherapy, antibody drug conjugates. So we have come a long way from it being a dreaded disease with no hope to something which even at stage 4 can be we can prolong the survival of the patient, both quality as well as quantity, in a meaningful way. Next slide, please. The advances in management of NLCLC has improved survival as well, which is what we will be discussing ahead based on certain trials. Next slide. This slide tells us about the advances in treatment over time. It basically gives a temporal realization to our various trials about how the EGFR TKIs, the ALK TKIs, then other targeted agents like NTRK, ROS, MET, RET, and the treatment for them, as well as for non-targetable NSCLCs, there is the advent of immunotherapy, and now even antibody drug conjugates has changed the dimension and the way we look at these patients. Next slide, please. So molecular targets in NSCLC, there are many targets, and the ones which have FDA-approved targeted therapies at present are 7, which are EGFR, ALK, ROS, RET, MET, NTRK, BRAF, V600E, and as discussed by Dr. Bhushan sir previously, we have appropriate standard treatments for all these markers. Next slide, please. We can go to the next one. So the treatment of early stage NSCLC, that is non-metastatic. So this the adjuvant treatment of a stage. So the adjuvant treatment will be based on whether it is an R0 or resection or not. So in case of an R0 resection in stage 1A disease, we can observe, we don't need to give adjuvant chemo. In case of an 1B disease, 1B and 2A, the chemotherapy versus observation discussion has to be done in a multidisciplinary board, and a decision has to be taken accordingly. For a stage 2B and beyond, chemotherapy is indicated, plus minus RT. In stage 3B, both CCRT followed by consolidation immunotherapy, as we will discuss later, is also a treatment option. However, in case this was all for an R0 resection, if it is an R1 resection, then we either give radiation along with chemotherapy or in a sequential manner, or we can also go for a re-resection in case of a stage 1A disease. If we are giving if it's an R1, that is, there is a microscopic residual tumor, then we can either go for a sequential or a concurrent chemoradiation. And in case of an R2, we go for a concurrent chemoradiation. Next slide, please. So even after initial treatment, even after all these advances, more than half of the patients with resectable non-small cell lung cancer have a recurrence within 5 years. And overall outcomes still need to be improved for patients with resectable NSCLC. Next slide, please. So, as per the ESMO guidelines, adjuvant chemotherapy can be considered in patients with resected stage 1B disease and a primary tumor more than 4 centimeters. So, post this trial, the staging had changed, and the stage 1B tumor more than 5 centimeters is now classified, more than 4 centimeters is now classified as a stage 2A, stage 2 disease, and adjuvant chemo is definitely recommended on those patients. And in stage 1B patients, as per AJCC 8th edition, that is 1 to 2 centimeters, still in high risk patients, adjuvant chemo can be considered after multidisciplinary discussion. Next slide, please. This latest meta-analysis showed OS benefit from post-operative cisplatin in early stage NSCLC. And this cisplatin improved OS with an absolute benefit of around 4% at 3 years and 5.4% at 5 years. And the hazard ratio was 0.89. Next slide, please. So when we talk about induction chemotherapy, the benefit with when we compare an induction chemo versus adjuvant chemo is more or less similar. They have a very, very similar hazard ratio of 0.87 and 0.89 respectively. And the regimens are also similar. Next slide, please. So this slide tells us about the ADAURA trial, and in the adjuvant setting, all as well, EGFR TKI osimertinib has shown a DFS benefit as well as an OS benefit. So this trial included patients with resected stage 1B to 3A EGFR mutant NSCLC, which was either a del19 mutation or an L858R mutation. And they were randomized post resection to either osimertinib or a placebo. And at 24 months, we can see that the curves have separated beautifully, and DFS has improved from 44% in the placebo arm to 90% in the osimertinib arm. And hazard ratio is 0.2. Next slide, please. Atezolizumab also showed an improvement in the adjuvant setting in both DFS as well as OS in patients with positive PDL1, and other agents are also under trials in the adjuvant setting. Next slide, please. Coming to radiation in early stage NSCLC. So as of now, the technologies have advanced a lot, and this has led to better outcomes with lesser side effects. IMRT, that is intensity modulated radiotherapy, has shown improved survival for patients with stage 3 NSCLC and T3 or T4 tumors. This advancement in technique has resulted in a reduced dose to the heart with lower rates of grade 3 or more pneumonitis. And thus, the side effects have come down considerably. Next slide, please. So it is important to differentiate between SBRT and conventionally fractionated external beam radiation, which for stage 3 NSCLC, as we've discussed, is IMRT. SBRT is high dose per fraction, that is 8 to 20 gray per fraction in 1 to 5 fractions with a 3D target localization. And SBRT is used in early stage lung cancer, but due to concern for toxicity, it is not used for larger tumors, that is more than 5 centimeters and N2 nodes. In that case, we use conventional EBRT with an IMRT technique. Next slide, please. The 4D CT planning now allows for margins around the tumor to be minimized. IGRT ensures accurate target coverage for every treatment while reducing margins needed to cover the tumor. And adaptive radiation. So this basically creates a new radiation plan after target tumor volumes have reduced in size, which allows for normal tissue sparing. So this is basically real-time adjustment, and as a result of this, the amount of radiation going to the normal lung parenchyma and the adjacent structures like the heart, esophagus is much lower, and toxicity has, as a result, come down significantly. Next slide, please. So this was an art. This slide shows the results from RTOG 061 trial, which compared conventional versus high dose RT, and in stage 3A and 3B NSCLC. So we can see that there is no benefit of giving a higher dose RT, that is of RT dose escalation. And with advent of now is immunotherapy, which is added to the CTRT backbone, stage 3 NSCLC is now a potentially curable disease. Next slide, please. So this we discussed in the previous slide as to how the adjuvant treatment post surgery will depend on whether it is an R0 or R0 or non-R0 resection, and adjuvant chemo as well as RT indication we have discussed. Next slide, please. So this checkpoint inhibitors, that is immunotherapy, both anti-PD-1, anti-PD-L1 agents. So this their role started in the metastatic setting. However, they are moving up the ladder, and we have started using them in both NACT as well as consolidation post CTRT. So this specific trial was a randomized double-blind placebo-controlled phase 3 trial of consolidation durvalumab in unresectable NSCLC post CTRT, and this trial has showed a significant benefit, as we can see in the curve. Next slide, please. Durvalumab demonstrated a 43% OS benefit at 5 years, and in comparison, this has a significant benefit as in a unresectable stage 3 NSCLC earlier. The 5-year survival was hardly 15 to 25%. Next slide. So now we come to the emerging treatment paradigms in NSCLC, which is targeted therapy and immunotherapy. Next slide, please. So targeted therapies are improving outcomes in advanced NSCLC. Almost 50% of patients with advanced non-squamous NSCLC have a driver mutation targetable with an FDA-approved agent, or allow for enrollment in a clinical trial. So the FLORA trial, which was recently published, it showed a significant PFS benefit of osimertinib versus first generation EGFR TKI in advanced EGFR mutant NSCLC. The median PFS is approximately 19 months with osimertinib and around 10 months with first generation EGFR TKI. Similarly, in ALK rearrangement positive NSCLC, alectinib showed a significant PFS benefit over crizotinib as per the ALEX trial. The median PFS with alectinib was around 35 months and around 11 months with crizotinib. So these the advent of these TKIs, EGFR, ALK, ROS, etc., has increased our median PFS and OS. With the chemotherapy earlier, the median PFS was hardly 5 to 7 months, and stage 4 lung cancer was thought to be a dreaded death sentence for the patient. However, with EGFR TKIs and ALK inhibitors, the PFS has gone up to around 19 and 35 months respectively. Next slide, please. There are also other emerging molecular targets which are being studied in trials, which include for MET exon 14 alterations, crizotinib is being tried. For RET rearrangements, cabozantinib and vandatanib is being tried. For NTRK rearrangement, larotrectinib and trectinib, and for HER2 mutations, TDM1. So newer targeted agents are being identified, and this will help increase survival in these subset of patients. Next slide, please. So the survival outcomes, as we have discussed, have improved significantly with these targeted agents, and as compared to chemotherapy alone. And this is true across all these targeted agents, such as EGFR TKIs, ALK TKIs, ROS, RET, MET, NTRK, fusion inhibitors, etc. And this has shown. This shows the various trials which have shown a benefit with these newer agents. Next slide, please. Coming to immunotherapy in NSCLC. So basically, the immunotherapy is the recent advancement in cancer treatment, which helps the body utilize its own immune system to fight the cancer cells. So the two main agents are either anti-PD-1, PD-L1 blocker or anti-CTLA-4. So PD-1, PD-L1 interaction does not allow the T cell to fight against the tumor cell. So blockage of either the PD-1 or the PD-L1 allows T cell activation, and thus the body's T cells themselves wake up and fight against the tumor cells. Similarly, CTLA-4 blockers also help the T cell wake up and fight the tumor cells. Next slide, please. So over time, many immunotherapy agents, both PD-1, PD-L1 as well as CTLA-4 blockers have been approved, and at present in advanced metastatic NSCLC are first line treatment options, as we will discuss. Next slide, please. Next slide. So this trial, so basically if irrespective of PD-L1, we can, in advanced NSCLC, we can give immune checkpoint inhibitors, pembrolizumab, along with the chemotherapy backbone. However, if the patient's PD-L1 TPS is more than equal to 50%, then a single agent pembrolizumab compared to chemotherapy showed a significant PFS benefit, and this was shown in Keynote 024. And almost 32% of patients were alive at 5 years with the use of immunotherapy in metastatic NSCLC. Next slide, please. So checkpoint inhibition, as we had discussed, started in the metastatic setting. However,
Dr. Rahul,
yes,
you can conclude in next 2 to 3 minutes, please.
yes, sir. So checkpoint inhibition is now moving to the neoadjuvant as well as adjuvant setting, and is not limited to stage 4 disease, as we have discussed earlier. Next slide, please. So apart from immunotherapy, what else is new is these antibody drug conjugates. Next slide. As well as CAR T cell therapy. This is still under study and currently is not freely available. Next slide. So the key takeaway messages from our discussion today is that the management of NSCLC is fast evolving, and we see that every few days or months there is a new approval. The newer therapies have a huge potential to improve survival, especially when detected in early stages. And the OS has improved across various subtypes with molecular alteration, and approximately 50% of the patients can have this molecular alteration, and thus the ease of administering this treatment with just a patient having to take oral pills at home is something which is a boon for these patients. And pulmonologists will play a huge role in early diagnosis, and hence it is crucial to involve them in our lung tumor boards. Thank you.
Yeah, thank you, Dr. Raghav. It was a very concise delivery of the therapeutic landscape of the lung cancer patients. It is sometimes very challenging to manage these patients and to offer various guidelines-based managements or also. So thank you again. So I would like to
Thank
invite
you,
my
sir.
okay. So I would like to invite my next speaker, Dr. Nikhil Himthani. He had done his DM Medical Oncology from the prestigious GCRI Ahmedabad Institute. He is working as a consultant medical oncologist and hemato-oncologist at Batra Hospital. So he will be delivering the lecture on the recent advancement in the management of the early lung cancer patient, particularly the trial results of the ADORA trial. So Dr. Nikhil, good evening. Over to you.
Good evening. Thank you for the kind introduction. Can someone share my slides, please? So, good evening to all of you. Today, I'll be discussing regarding the newer paradigms in treatment of resected EGFR mutant early lung cancer. Next slide. So, lung cancer is the leading cause of cancer death, accounting for more than 1.7 million deaths annually, and as many deaths as breast, prostate, and colorectal cancer combined. And non-small cell carcinoma lung represents 85% of all lung cancer cases, with an estimated 30% of patients presenting with resectable disease at diagnosis. Just to clarify what is resectable disease, so early stage or localized stage is when the stage is 1B, in which the tumor is localized within the lungs, and regional and locally advanced is stage 2 and stage 3A, when the disease has involved ipsilateral group of mediastinal lymph nodes as well. Next slide. So, as we know that in resectable non-small cell carcinoma lung, surgery is the primary treatment for these subgroup of patients. And after surgery, we give adjuvant cisplatin-based doublet chemotherapy as per the LACE meta-analysis, which has shown 5% improvement in overall survival at 5 years. So overall, still giving adjuvant cisplatin based doublet chemotherapy, still the recurrence rate is very high. The disease recurrence or death following surgery and adjuvant chemotherapy remains very high, as we can see that for stage 1B, the 5-year recurrence rate is nearly 45%, and for stage 2 it is nearly 62%, and for stage 3, after surgery and chemotherapy, the risk of recurrence is as high as 75%. Next slide. So, as we know that for stage 4 non-small cell carcinoma lung, we generally do the driver mutation analysis, and we look out for those EGFR, ALK, and ROS mutations. But not only for stage 4, now for stage 1 as well as stage 3, we do these driver mutation analysis so that we can select these subgroup of patients who are EGFR mutation positive for adjuvant osimertinib, which I will be discussing. And we can see that in Asian subgroup of population, the incidence of EGFR mutation is higher as compared to the US and European. The incidence is nearly 30 to 40% in the Asian subgroup population, while in Caucasian, the incidence is nearly 10 to 20%. Next slide. Now I'll be discussing the ADORA trial. Next slide. So ADORA was a phase 3 randomized controlled trial in which patients who had stage 1B, stage 2, and stage 3 non-small cell carcinoma lung after surgery and with or without adjuvant chemotherapy were randomized to receive adjuvant osimertinib versus placebo. and they included patients who were more than 18 years of age and had confirmed exon 19 deletion or L858R mutation. Next slide. So again, the inclusion criteria included patients who had age of more than 18 years and who had primary non-squamous non-small cell carcinoma lung, stage 1B to stage 3A, with EGFR mutation, exon 19 deletion or L858R mutation, and patients who had received post-operative adjuvant chemotherapy, platinum-based doublet chemotherapy for 4 cycles maximum, but not mandatory, and complete surgical resection of the primary and MRI or CT scan of the brain prior to surgery with ECOG PS of 0 to 1. Exclusion criteria were there, like patients who had received pre-operative radiation or pre-operative chemotherapy, and patients who had undergone segmentectomies or wedge resection were excluded. Patients who had cardiac comorbidities and QTC prolongation or arrhythmic events were excluded. Patients who had medical history of ILD or any uncontrolled systemic diseases were excluded. So baseline characteristics. So both the arms were well balanced with respect to sex, age, smoking status. Predominantly female patients were there. Nearly 70% of the patients were female, while 30% of the patients were male. Median age was more than 60. It was around 62 to 64 years. Predominantly non-smoker population was there. Around 70% were non-smokers, while 30% were smokers. Asian subgroup population again was the incidence was higher. Nearly 65% were Asians, while 35% were non-Asians. Importantly, nearly 95% of the patients had adenocarcinoma histology, while 3 to 4% had other histology. Importantly, 60% of the patient received adjuvant chemotherapy and 40% of the patient did not receive adjuvant chemotherapy. Next slide. So it was seen that addition of osimertinib after chemotherapy for 3 years improved the disease-free survival significantly. As we can see, the Kaplan-Meier curves are separating in favor of osimertinib with a hazard ratio of 0.17 in favor of osimertinib. So there was 83% reduction in the risk of disease recurrence or death with adjuvant osimertinib. Next slide. So we can see that the benefit of osimertinib was seen across all stages. In stage 1B, the 2-year DFS was 88% versus 71% in placebo in favor of osimertinib with hazard ratio of 0.39. For stage 2, again, we can see the benefit was there for osimertinib 91% versus 56%. And maximum benefit we can see for stage 3A, 2-year DFS of 88% versus 32%, again in favor of osimertinib with hazard ratio of 0.12. So it was the DFS benefit was seen across all disease stages. Now this is a forest plot which is showing that the osimertinib was better as compared to placebo across all subgroup of patients, irrespective of sex or age or smoking history. The benefit was seen across all subgroup of patients in Asians, non-Asians, stage, EGFR mutation. Surprisingly, patient who had exon 19 deletion did better as compared to L858R mutation, and patients who had received chemotherapy or not received chemotherapy, benefit was seen across all subgroups with adjuvant osimertinib. Next slide. Now coming on to overall survival. So this is basically old slide which is showing that at 2 years the curves are separating in favor of adjuvant osimertinib with 2-year OS of 100% in osimertinib arm versus 93% in the placebo arm. Now there is a recent update at 5 years which is showing nearly 10% benefit of adjuvant osimertinib, 77% in the placebo arm versus 88% in the adjuvant osimertinib arm. So OS benefit is also seen with the use of adjuvant osimertinib. Next slide. So previously, erlotinib, geftinib have also been tried in the adjuvant setting. All of these trials, like the SELECT trial, RADIANT trial, all have shown DFS benefit, but no OS benefit was seen with use of these previous generation TKI. Unlike osimertinib, which has shown a 5-year overall survival benefit as well. So, local regional recurrence is associated with longer post recurrence survival than distant recurrence. So, as we know that, and preventing CNS recurrence is an area of unmet need. And CNS is a common site of distant recurrence among patients with EGFR mutant non-small cell carcinoma lung receiving EGFR TKI. And in the adjuvant radiant study, 37% of the recurrence in patients with EGFR mutant non-small cell carcinoma lung treated with erlotinib had CNS involvement. And as we know that osimertinib has significant exposure in the brain and crosses the blood-brain barrier, so the incidence of CNS metastasis was significantly lower in the adjuvant osimertinib. In the advanced non-small cell carcinoma lung setting, first-line osimertinib demonstrated superior overall survival and 52% reduction in risk of CNS progression as compared with erlotinib and geftinib. Next slide. So very importantly, as we can see that 11% of the patient in osimertinib arm had DFS events, that is disease recurrence or death, versus 46% of the patient in the placebo arm. Most importantly, the recurrences in the osimertinib arm were local recurrence instead of distant recurrences. Nearly 62% of the patients had loco-regional recurrence, while only 38% of the patient had a distant recurrence, highlighting the need for more effective local modalities. While patients who receive placebo, most of the patient failed distantly. 61% of the patient had a distant recurrence, while 39% of the patient had local failure in the placebo arm. So again, the patients who receive osimertinib, as I have told previously, majority of recurrences were loco-regional. Lung recurrence and lymph node recurrence were seen in nearly 9% of the patient, while we can see the incidence of CNS recurrence is so low, only 1% recurrence, CNS recurrence with osimertinib as compared to 10% with placebo. So again, this is showing the same thing that with adjuvant osimertinib, the incidence of CNS recurrence is pretty low. It is only 1% as compared to placebo, which is 10%. Again, this is the curves which are showing that CNS disease-free survival was significantly better in the osimertinib arm as compared to the placebo arm. At 3 years, the CNS DFS was 98% in osimertinib versus 82% in the placebo arm. Now coming on to the adverse events, so osimertinib overall is a well-tolerated drug, and grade 3 adverse events were seen in nearly 20% of the patient in osimertinib versus 14% in placebo. Next slide. So majority of the patients had grade 1 and grade 2 diarrhea, that is 46%. Very few patients had grade 3 or grade 4 adverse events like diarrhea or stomatitis. Only 2% patients had grade 3 or grade 4 adverse events. So it's a well tolerated drug, and most common side effects like grade 1, grade 2 diarrhea, paronychia, dry skin, pruritus can be seen. And grade 1, grade 2 interstitial lung disease was reported in 3% of the patient in osimertinib arm, so we have to watch out for that. And we have to do repeated ECG since QTC prolongation can occur in 7% of the patients. It was seen in 7% of the patients in osimertinib arm as compared to 1% of patient in the placebo arm. So post-operative chemotherapy use and outcomes from ADAURA, which I'll be discussing that. Next slide. So as I've told previously, 60% of the patients received adjuvant chemotherapy, while 40% of the patient did not receive adjuvant chemotherapy. And majority of the patient received platinum-based doublet chemotherapy. And patient with stage 2, stage 3A disease 76% of the patient received adjuvant chemotherapy, while patient who had stage 1B disease, only 26% of the patient received adjuvant chemotherapy. Next slide. So again, we can see that irrespective of use of chemotherapy, patients who did receive adjuvant chemotherapy or did not receive adjuvant chemotherapy, adding osimertinib for 3 years 80 mg OD improved the DFS significantly in both subgroup of patients with hazard ratio of 0.16 and 0.23. Next slide. Again, this is a forest plot which is showing that the benefit of osimertinib is there across all subgroup of patients, irrespective of patients who receive chemotherapy or not. In stage 1, starting from stage 1 to stage 2 to stage 3, the benefit is there. Next slide. So for again, this is highlighting the same thing for stage 1B. We can see that adjuvant osimertinib improves the DFS as compared to placebo. Next slide. For stage 2, again, we can see the curves are beautifully separating in favor of osimertinib. Again, we can see the curves are getting wider and wider as the stage is progressing. So higher the stage, better is the benefit for adjuvant osimertinib. Next slide. Now coming on to patient reported outcomes from ADORA. Next. So this is the health related questionnaire which was used in the ADORA trial, SF36. It is basically a generic health survey, and it consists of two summary scores. One is the physical component summary and other is the mental component summary. And there are 8 health domains which include the physical functioning, role physical, bodily pain, general health, vitality, social functioning, role emotional, and mental health. So this questionnaire was used in the ADORA trial, and data collection was done at the time of surgery and chemotherapy, and after at the time of randomization, and once the patient was on osimertinib, it was done at week 12, 24, and every 24 weeks. Next slide. So the compliance was adhered, and the compliance rate was very high. It was more than 85% in both osimertinib arm and the placebo arm. Next slide. So during the disease-free period, the majority of patients, nearly 80% of the patient, did not experience a clinically meaningful deterioration in PCS or MCS, that is physical and mental component summary. And for those patients who had deterioration, there was no difference in TTD of PCS between osimertinib and placebo. Next slide. So just to summarize my talk, adjuvant osimertinib is the first targeted agent in a global trial to show a statistically significant and clinical meaningful improvement in DFS as well as OS in patients with stage 1B, 2, 3A, EGFR mutant non-small cell carcinoma lung. There was 80% reduction in risk of disease recurrence or death with adjuvant osimertinib, and DFS rates at 2 years were 89% versus 52%. Also, adjuvant osimertinib demonstrated clinically meaningful improvement in CNS DFS compared with placebo, and the safety profile was consistent with the established safety profile of osimertinib, with mild EGFR TKI class effect reported. Median duration of exposure to osimertinib was 22 months. Clinically meaningful DFS benefit was seen, as I've discussed, as well as OS benefit was seen. And adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with resectable stage 1B, 2, 3A, EGFR mutant non-small cell carcinoma lung. Thank you.
Thank you, sir. It was exceptionally clear and the concise presentation. I have a quick questions to you. So since we have the overall survival data from the ADORA trial, so how confident you to offer the patient for a with a disease free for a therapy for a 3 year something? So is there certain patients group do you want to select, or all comers fulfilling the inclusion criteria of this trial?
So patients who have been resected stage 1 to stage 3 lung cancer and have received adjuvant chemotherapy or not, and if the patient is having EGFR exon 19 deletion or L858R, I would consider for adjuvant osimertinib 80 mg OD for 3 years, provided the patient is tolerating it well. Since we have a strong data to support it, support as per the DORA trial, which has shown OS benefit as well as compared to the other previous generation TKI which have not shown any OS benefit. So this is the first drug which has shown, apart from DFS benefit, a OS and a benefit also. So I strongly consider osimertinib adjuvant in my clinical practice.
Yeah, definitely, sir. Since we have a plethora of the agents after progressing over the osimertinib, so there was a glitch in managing or offering the osimertinib is that key. Once the patient progressed on the osimertinib, what could be the options? So we have number
Yes,
of options in our armamentarium this time. So
yes,
definitely, since we have the OS data, which is quite encouraging, we should be offering all these patients. Now we have the data of the LAURA trial also. So definitely, these targeted therapy are way to go.
yes.
So thank you, sir. Thank you. It was a lucid presentation. Uh,
Thank you
so
so much.
so I would like to so so I would like to present the final talk of the day. So if my slides are visible, tech team,
Yes, sir.
please confirm.
Yes, sir.
Yeah, so the final talk of the day is decoding the treatment options for the EGFR mutated metastatic NSCLC patients. So again, this is the repetitions of the previous um, uh, slides which has been presented. The epidemiology of the lung cancer in comparison to the other cancer per se. So as per the Globocon 2020 data, lung cancer remains to be the second most common malignancy across both the sexes. And again, it remains to be a formidable condition, and it leads to the around 18% of the cancer related death across all the types. So definitely the management of the metastatic NSCLC patient, particularly the EGFR mutational profile, the treatment choice will depend upon several parameters, including the data of that particular agent favoring the progression-free survival advantage. Then again, OS is very important. Overall response rate, again, very important endpoint. Then again, the efficacy, intracranial response rate is also very important while selecting these agents. Then the safety and the toxicity, how it affects the quality of the life of the patient. And then again, what are the agents do we have after progressing on that particular agent? So definitely, if we see this chart, which is a snapshot of all the median PFS we have along the various TKI agents, various generations of the TKI agents in the EGFR mutated patients. So definitely, we say that in first generation TKI patient, we have a median PFS of around 12 to 14 months. Then with second generation, particularly decometinib, as per the Archer 1050, median PFS reaches to the tune of 14.7. But very importantly, in the FLORA trial, the osimertinib reaches to the landmark of 18.9 months, which was very first time in the history of the metastatic NSCLC patients. If we see the cross trial comparisons, since we should be taking all the cross trial comparisons with a pinch of salt, but to compare all these trials in a nutshell, then again, as per the Lux Lung 7 trial, where it compare the role of the afatinib as compared to this afatinib, the curve starts separating after a 12 months of period. So the advantage of the afatinib over gefitinib has been shown to start after 12 months of the therapy. Again, in the Archer 1050, the curves started separating after a therapy of 6 months. And there was an advantage of using second generation dacometinib over the first generation, which was gefitinib. The median PFS was 14.7 in the dacometinib arm versus 9.2, which was statistically significant. But the catch is, all the patients which was included in the Archer 1050 was free from the brain metastasis upfront. Then comes the landmark trial Flora, where the osimertinib was compared with the standard of choice, which was the gefitinib or the erlotinib, and we can see that the median PFS curve, KM curves of both the arms were started separating immediately after the commencement of the therapy, and they have included around 19% of the patients with the stable brain mets. It reaches a median PFS of 18.9 versus 10.2 with a considerable HR of 0.46 with a significant p-value. So early separations of the PFS curve was shown with osimertinib alone. Then if we compare the overall response rate across all the EGFR mutated targeted agent 2 we have, as per the Lung 7 trial, afatinib has an overall response rate of 70%, while the first generation, which was afatinib, it was only 56%. And if we compare it with the Flora, the osimertinib third generation EGFR TKI, the overall response rate reaches to the tune of 80% as compared to the comparator, which was only 76%. And in around 3% of the patients, in around 7% of the patients, in around 3% of the patient, the CR was even reached as compared to the other one, which was only 1%. If we see the data from the Archer 1050, dacometinib had an overall response rate of 75% versus 72% with the use of the first generation TKI. So definitely osimertinib across all these three generations of the TKI had a highest overall response rate along with the highest median duration of the response. If we see in the Flora trial, median duration of the response with the osimertinib was 17.2 months versus 8.5 only. So there was a doubling of the median duration of the response with the use of the osimertinib in the upfront setting of the EGFR mutated NSCLC patient. Then again, this PFS, duration of response, and the overall response rate endpoints reaches finally to the significant value of the overall survival advantage. So if we see these KM curves, then again, at the milestone of the 12 months, 24 months, and 36 months, all these separated curves shows the superiority of the osimertinib over the comparator, which was the first generation gefitinib or the erlotinib. So at the landmark of 3 years, the the overall survival probability was 54 months in favor of the osimertinib, which versus only 44 months for 44% in the comparator EGFR TKI arm. So there was a clear-cut delta of 10% favoring the osimertinib alone. And if we see the final median overall survival point, it was 38.6 months with the use of the osimertinib, while only 31.8 months with the other first generation EGFR TKI arm with the HR of 0.799. That means around 21% advantage of using osimertinib, or there is a probability that this osimertinib, with the use of the osimertinib, there is a probability of surviving 21% more. Then this landmark of 3 years was first time reached with the use of the osimertinib EGFR TKI. And definitely osimertinib patients were more likely to be alive at the second and the third year landmarks as compared to the first generation EGFR TKI agent. If we compare the same overall survival data from the other second generation TKI, particularly the afatinib and the dacometinib, then as per the Lung 7 trial, this was a non-statistical overall survival curve. So the median PFS do not transformed in the overall survival advantage in the Lung 7 trial. Similarly, Archer 1050, since it was a hierarchical study design where they first conducted a study or analysis to prove that it is favoring the PFS. Then, if it favors the PFS, they conducted the overall response rate analysis. Since the overall response rate analysis was not statistically significant, then the formal statistical hypothesis testing for the OS was not conducted. So, although there was a numerical advantage in the overall survival with the use of the dacometinib, which was 41 months versus 33.6 months, but it was not statistically analyzed, or not the p-value could not be given to the OS. Since it was a hierarchical study design, they do not reach the overall response rate was not reached to the statistical and significant advantage. They do not conducted a analysis for the overall survival. So only osimertinib had a overall survival advantage over the other comparator EGFR TKI agents. Then again, if we see this curve, then there was a 28% the 28% of the patients were still receiving osimertinib at the 3 years. So as compared to the other first generation TKI, only 9% of the patients were on the treatment at the 3 years, while uh, around 3 times of the patients were remains over osimertinib at 3 year. Then if we see a subgroup analysis where they compared the PFS probability across the brain metastatic patients or not. So with the known treated CNS metastasis, the probability of the PFS again favors the osimertinib arm. So the median PFS in such patients who were having a upfront CNS metastasis reaches to a 15.2 months versus 9.6, again with a significant HR of 0.47. Similarly, the advantage was there in all those patients who were not having the CNS metastasis at presentation. So to conclude, the CNS progression events occurred in 6% versus 15% in the patients who were using the osimertinib versus standard of care respectively. Then again, if we see an intracranial response rate or the intracranial PFS analysis, so median CNS PFS was not reached in the osimertinib arm, while it was 13.9 months in the standard of care, which was first generation EGFR TKI, with a significant HR of 0.48 again. So again, intracranial progression-free survival again favors the osimertinib arm. If we see if we see this CNS response across other trials, where they are using the other second generation TKIs, including the afatinib, dacometinib, the overall response rate was only assessed in the FLORA trial with the use of the osimertinib. So the CNS evaluable for the response rate was 66 in the osimertinib versus only 43 with the other EGFR TKI, which was first generation. In the dacometinib, the study did not include any upfront brain metastatic patients. In afatinib, there was a baseline asymptomatic brain mets were included, but they do not conducted a separate response rate analysis in the CNS events. So again, the osimertinib is only the agent which had shown or which has been assessed for the intracranial response rate. So very importantly, if we see a safety profile across other comparator EGFR TKI agents, the osimertinib, the grade 3 or 4 adverse events with the osimertinib was there in the 18% of the patients in the FLORA trial, while it was there in 63% with the use of the dacometinib as per the Archer 1050 trial. And the similar higher number of the events were there with the use of the afatinib in the Lux Lung 7 trial. So if we see the most common grade 3 or more grade 3 or more adverse event with the use of the osimertinib was loss of appetite, diarrhea in 2.2% of the patients. Prolonged QTC prolongation was there. 1.4% of the patient had a fatigue, and 1.1% of the patient had a rash, maculopapular rash. While with the use of the dacometinib as per the Archer 1050 trial, the most common adverse event were dermatitis acneiform in about 14% of the patients, diarrhea in 8% of the patient, and the other side effects are paronychia, hypokalemia, and so on. If we see these side effects in a single slide, so the most common side effect, which is skin rashes or skin reactions, which was in 14% with the use of the tacrolimus. With the use of the osimertinib, the skin reactions limited to less than 1% only. The other side effects were considerably lesser, and again favoring the use of the osimertinib in the safety settings also, along with the efficacy superiority. So again, in FLORA, the frequency of the dose reductions was similar between the osimertinib versus the standard of care EGFR TKI, while in the Archer 1050, the dose reduction was there in 67.4% of the patient with the use of the dacometinib, which was considerably high. Similarly, with the use of the afatinib, which is again a very, can say, a very difficult drug to manage in certain patients, the dose reduction was there in 42% of the patients as per the Lux Lung 7 trial. So again, the safety is again favoring the osimertinib. Then if we see the quality of the life data, which is quite very, sometimes very crucial, particularly if we are offering certain kind of the therapy to the patients, then again it favors the osimertinib. So as per the FLORA trial, the global quality of the life was improved in the patients across all the symptoms, which could be cough, dyspnea, pain in chest, or appetite loss and the fatigue. While with the use of the dacometinib, as per the Archer 1050 trial, the diarrhea rates are very high, sore throat, and again very high, and overall quality of life is again at least maintained and some numerically deteriorated at least. So why it is important to offer the patient or offer all these EGFR mutated patients to the osimertinib upfront? So we there is a dilemma, we can say, that patient that we can also offer these patients in the next line setting also. So definitely it has been seen that only 1 out of the 3 patients, they have received the osimertinib in the second line after progression of this thing. And in remaining patients, it is not possible to predict who will develop the T790M mutation resistance. So definitely, it has been seen that if we want to give a advantage of these safety and efficacy data to all these patients, we need to give or offer the patients with the osimertinib upfront. And then we can say that as per the other trial like IPASS, URTEC, Optimal, Ensure, and CTONG, it has been seen that only it has been seen that 50 to 70% of the patients only received subsequent therapy. That means around 50 to 30 to 50% of the patients do not have do not opt for or do not even fit for the next line of the therapy on progression. Then they finalized that what is the real world evidence of the T790M mutation after afatinib. So it has been seen that since T790M mutation remains to be the most common type of the mutation on first and second generation TKI, in Japanese studies, around 43% of the patients, they acquired T790M mutation. Same with the Taiwanese study. In another Taiwanese studies, around 32% of the patients or after afatinib developed T790M mutation. So around 40 to 50% of the patients on progression on first, second generation TKI developed T790M kind of the mutation. So if we frame algorithm that after progression on the first or second generation, we offer the third generation, most of the patients, they will not, even around 30% of the patient, they will not get certain kind of the, even some kind of the therapy at least. So there are certain controllable factors also in sequencing that, again, the fitness of the patients, patient's choice, concurrent morbidity, then what is the site of the progression, whether there is T790M mutation present or not, or if there is certain transformation of the histopathology or not, and again the toxicity of the drugs also. So considering all these safety, efficacy, and then the other data also, it is being recommended, and most of the international guidelines also recommended it as a category 1 indications in the first line osimertinib first line setting alone. Then comes certain real world studies which depicted the role of the superiority of the osimertinib across other agents also. So this was the flower study, which is first line osimertinib in the real world and inter-regional prospective study. So this was the study conducted at Italy, 9 centers of the Italy, where they recruited around 126 patients, and they found that time to treatment discontinuation was 25.5 months, 25.3 months with the use of the osimertinib. And they found that 18.8% of the patients, they reached a median time to treatment patients in patients with or without symptoms at diagnosis. Similarly, progression-free survival also reaches to the FLORA data, which was 18.9 months. So definitely then again, flower study also shows the superiority of the osimertinib in the real world setting. Then they concluded that the osimertinib confirmed effectiveness and the safety in the real world, although thromboembolism was more frequent than previously reported. So in this real world setting, the propensity of the venous thromboembolism was more. Any grade venous thromboembolism was there in 9.5% of the patients. So this was some new kind of adverse event was shown in the flower study. Rest, diarrhea, skin rashes, paronychia, along with certain lesser rare side effect like QTC prolongations was again shown with osimertinib in the real world setting also. Then the other study which was conducted at Japan, which is OSIFACT, which is osimertinib as the first line treatment for the advanced EGFR mutated NSCLC patients. So they recruited around 538 patients. They included all those patients with the exon 19 deletion, exon 21, which is L858R mutation, and around 5.5% of the patients with the uncommon mutation were again enrolled. They found that the overall response rate was 76%, median PFS a bit higher, which is 20.5 months. So again, these real world also reflecting the trial setting, and it reaches to the same wall park figure also. And if we see the safety profile, again, pneumonitis was the most common side effect. Around 12.8% of the patient have some kind of the grade, some kind of all grades of the pneumonitis. And they concluded that again, PFS was concurrent with the real world setting. PFS was concurrent with the trial setting outcome, and the discontinuation rate due to adverse event, especially pneumonitis, requires further investigation. Then the next real world study was Mykonos. It was again conducted at USA, Japan, Germany, and China. And again, they enrolled around 534 patients with the adenocarcinoma, 7 with the squamous cell carcinoma. And they analyzed the interim real world TTNT, TTNTD, which is time to next treatment or the death, which is a more better, or we can say endpoint in the real world setting. It again favored the osimertinib with the median real world time to next treatment or the death was 17.9 months. So again, various guidelines also recommended or preferred or recommended the osimertinib as a preferred category 1 indications in the EGFR exon 19 deletion or the L858R mutated NSCLC patients, particularly in the first line setting. Similarly, this ESCO living guidelines also recommended osimertinib monotherapy as of now. So to conclude, as per the FLORA trial, with the use of the osimertinib in the first line setting of the EGFR mutated NSCLC patients, it reaches to a significant improvement in the median PFS, which also transformed into the OS benefit also. So nearly 30% of the patients, they remained on the osimertinib at the 3-year landmark. And again, safety profile also favors the osimertinib, and sequencing cannot be considered as the best strategy, as around 70% of the patients are not eligible for the osimertinib in the second line. So with this, I would like to conclude my talk. If there are any questions, I can try to answer those queries. I think we can conclude the meeting. So thank you all the esteemed attendees for being a part of this academic fest. Thank you, Dr. Bhushan sir, Dr.
Thank you,
Raghav,
sir.
and Dr. Nikhil sir also.
Yeah, I would like to ask a question for the stage 4 non-small cell carcinoma lung, like squamous cell carcinoma. Do you routinely do molecular testing, EGFR Alcross in all patients, or is there any specific subgroup?
Yeah, definitely, sir. So we have a separate lung panel. So where we enrolled around eight most commonly identified genetic mutations or fusions. So we have framed a separate dedicated lung NGS panel in our molecular lab. So we try to offer all those newcomers, irrespective of the histology, be it with the squamous or the adeno, to offer these testing. So we are also conducting some thesis work on this thing also. We are also sending the liquid biopsy for the NGS in the squamous patients also.
Okay. And what is the incidence you get a mutation for squamous?
So again, this is challenging. So only 5% of the patients have the EGFR mutation in the this squamous patients.
Okay. And for adenocarcinoma with EGFR exon 19 or L858R, after osimertinib, if there is a frank disease progression, next line of, do you do a repeat NGS or you opt for chemotherapy?
Yeah, sir, we are usually repeated the biopsy and send it for the NGS again.
Okay.
And if the tissue is not available, we have a facility to send it with the liquid biopsy also.
Okay. And is there any discrepancy in the liquid versus solid? Is there any study in RGCI which I just curious to know?
So we have conducted the EGFR by RT-PCR and assessed the concordance between the EGFR between the liquid biopsy and the tissue-based testing. So
Okay.
the concordance was around 90 to 93% in both these
Okay.
modalities.
So liquid biopsy is also accurate.
Equally,
Okay.
definitely. And we have sent the CSF also, pleural fluid also.
Okay.
It has a equal sensitivity again.
Okay.
So mostly, I think it depends on the laboratory. Multiple factors are there, including the extraction of say leke, then the analysis. It depends upon the how well calibrated your this thing is, tissue
Mm-hmm.
testing or the.
And if the patient progresses on osimertinib first line in adeno-CA EGFR mutation, next line of treatment is what, chemo or immuno? What is the preference?
We usually restricted with the use of the immunotherapy.
Okay.
if unless there is very limited data that if the patient had a C797M mutation,
Mm-hmm.
that patient we can also offer the first generation TKI. So there is very specific recommendations where we can use the first generation, which is gefitinib, erlotinib, post progression of the third generation if it is having the C797M mutation. Rest mostly we use the chemotherapy, conventional chemotherapy.
Okay.
We have certain studies where this amivantamab and the lazertinib was also offered.
Okay. Mariposa trial.
Mariposa and then papilloma.
Okay. And are you offering osimertinib and chemotherapy as first line?
Not yet.
Not yet. Only
So some-
osimertinib.
mostly. We
Okay.
have the data from the Flora too, but we
Yes.
are not usually used those combinations.
Okay.
We can use in very selected patients where the tumor volume is very high. Then we can certainly offer some patients.
Thank you.
Thank you again. So over to the tech team. We can conclude our meeting as of now.
Thank you everyone for joining. Thank you, sir.
Thank you. Good night.
Thank you everyone for joining. Thanks for a good sessions and talk. Good night, everyone.
Good night, everyone.
Support team, you can close the meeting.
Okay, ma'am.